Welcome, everybody. Good afternoon. This is the January 2023. My script says 22. I didn't update that. Just caught it. Quarterly APCD data users group. It's our 14th since we've started the APCD. For those of you who you may have noticed in the registration that this blocks an hour and a half of time. This will not be an hour and a half. Typically, it's an hour from noon to 1 Central. So rest assured that it is unlikely to take more than an hour. So for those of you who are new to these sessions, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, the AHTI, and is administered by the Arkansas Center for Health Improvement, or ACHI. That is us. The Arkansas APCD is comprised of private carrier and public payer, medical, pharmacy, and dental claims, as well as enrollment data and provider data. And additionally, under the HTI umbrella, the HTI enables the use of key data sets from the Arkansas Department of Health, including vital statistics data, hospital discharge and emergency department data for those who indicate self-pay or uninsured, cancer registry data, and a limited amount of medical marijuana cardholder data. We have some Arkansas workers' compensation data as well, though it's very limited and customized. If you're interested, do reach out and we will help you with that. So we hope that you find today's session helpful. Some housekeeping before we move forward. Feel free to type your questions in the chat at any time. Kathy Hart, you see, she's going to manage all of the questions. At the end of today's session, we'll provide a link to our service desk application where you can enter any question or topic you want that you want to dig deeper into, or you're just interested in being a topic for the next data user group. The Arkansas APCD data, any APCD data, can be very complicated. So you can also request time with our team to address specific questions you may have about the data and how to interpret the data. We are here to help you. The link to the deck will be provided in the follow-up email. You'll receive this after the conclusion of the session. It will also include the video of this recording. And finally, mark your calendars. The next data users group is April 26, 2023. Next slide, Jennifer. Let's talk about the agenda. We have a full agenda, and yes, I said it won't take more than an hour, and we're going to stick to an hour. We'll get as far as we can, but we have a featured project, and I'm so excited that this is going to kick this session off. We like to feature projects that use our Arkansas APCD data for their own output and research. And we have a special one here today, the project title, AHRQ Innovations in Physician Practice, and Social Determinants of Health Data. And it's presented by AHRQ and NORC, NORC. You can read the slide. Our second topic is from our Arkansas APCD analytic team, Arkansas Breast Cancer Screening Analyses, and this is expanded to talk about inclusion criteria methodologies. We have a couple of slides of questions and information from other APCDs. It's always good to know what else is going on. And then we have the latest release information and data tips for our own APCD and questions and answers as needed. So let's go to the next slide. The presenters, me, Henley Money, Director of Information Systems Architecture and the APCD Director here at ACHI. Dr. Herbert Wong, Director of the Division of Statistical Research Methods from AHRQ. There's much more to his bio. We're going to let him fill that in. Dr. Jennifer Smith from NORC, the Principal Data Scientist. Mike Motley and Sarah Crawford from ACHI's Analytics team. Next slide, please. So let's go into our featured topic. And I'll just, Jennifer, please, let's turn the presentation over to Jennifer, Dr. Smith, yes? And she will take it from here.
Thank you, Henley.
Yeah. Go ahead. Go ahead.
So, did you send me a copy of the slides?
Oh, I thought you had the ones from yesterday. Stand by, please.
Otherwise, you can control them. Herb and I can just say,
okay.
Yep.
Because we had, yeah. All right, Jennifer, I sent Jennifer Medley. I sent a second link to their slides. If you wouldn't mind bringing it up and then taking the presentation back.
Sure, I'm working on that right now.
There's always a backup, right?
Apologize for the confusion.
No worries. So as we wait on Jennifer Medley to bring that up, Jennifer is one of our project managers. Dr. Smith and Dr. Wong, would you do introductions?
Yes, so let me start off. So my name is Herb Wong. I am the director of the Division for Statistical Research and Methods here at the Agency for Healthcare Research and Quality. I've been with the agency for a little bit more than 30 years, and much of my activities have been focusing in on research from the economic side as well as data development activities. And so the group that I lead not only focuses on statistical research and methods, but also data innovations as well. Jennifer?
Thanks, Herb. Good afternoon. My name is Jennifer Smith. I am a principal data scientist at NORC, and my expertise lies in healthcare claims, specifically in Medicaid claims, but I have used both Medicare and APCD claims, hospital discharge data information, and other associated healthcare administrative data sets throughout my career. I led the effort to create the physician or not led the effort, but led the team, the data team, to pull the data and create the physician and physician practice data sets that we have worked on with AHRQ.
Thank you so much. I believe we are ready with the slides. And so Jennifer Medley will present. Let's open it up. And then you can ask her to move forward as necessary.
Yep, I will do that. Okay. So terrific. So let me get started. The title of our presentation is Creating the Physician Practice Research Database. So for the next 15 to 20 minutes, Jen Smith with NORC and I will describe to you a new database that AHRQ has sponsored, which we call the Physician Practice Research Database. Because I am a big Star Wars fan, the naming of the database was actually quite intentional, so that the acronym is actually called 3PRD. I think I mentioned that I am trained as an economist. I spent my years really conducting research and policy analysis and data development activities. And like many people here at AHRQ, really the combination of conducting research and involvement in data development activities really gives us an advantage of building a research database that we find useful to the field. 3PRD is actually a larger AHRQ initiative that we call AHRQ Data Innovations. And under AHRQ Data Innovation, it's really an effort to identify existing data gaps and to help build prototype databases so that we can begin to fill in these data gaps. And so for today's presentation, I'm going to start off by really providing you with some motivation for this particular data development effort. And then I'm going to turn the floor over to Jen, who's going to provide you with some of the high-level overview of how the database was in fact built. Next slide, please. So AHRQ is actually one of 12 operating divisions within the U.S. Department of Health and Human Services. And AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, affordable, and to work with the Department of Health and Human Services and other partners to make sure that the evidence is understood and in fact used. Now, AHRQ achieves its missions largely through funding healthcare research, but AHRQ also funds its research through grants, but also conducts certain initiatives through different contracts. In addition to this, AHRQ has had a long history of database development and dissemination. The flagship data programs include the Medical Expenditure Panel Survey, or MEPS, and the Healthcare Cost and Utilization Project, also known as ACHI. Next slide, please. So over the last several years, there has been a growing recognition that the national healthcare environment has in fact been changing. As new issues on healthcare delivery emerge, policy analysts are really beginning to recognize that they do not have really the right databases to properly address many of these issues. In general, there's a growing recognition that more data are needed to inform both public and private policy, especially to address issues related to equity, health insurance coverage, healthcare markets, and competition. Now, 3PRD was particularly motivated by the COVID national emergency that took place beginning in March of 2020. As the COVID national emergency emerged, the U.S. Department of Health and Human Services was seeking information to help inform how the CARES Act Provider Relief Fund would be distributed. The department approached AHRQ with many requests for information, and we were able to provide many answers to questions with our existing data sources. So for example, information on hospitals, we were able to provide information along those lines to them. However, there was really no comparable information for physician practices. And in general, the COVID national emergency highlighted some serious data gaps to inform policy. Now, as you think about this, hospital care represents roughly 32% of the national healthcare expenditures. And the next largest category is physician and clinical services at about 20%. Now, AHRQ has had long recognized this information gap on physicians, and in the fall of 2020, AHRQ decided to invest some resources to begin addressing this data gap. The Physician and Physician Practice Database, or 3PRD, is AHRQ's initial effort to close this data gap. So with that, I'm going to turn the session over to Jen to describe AHRQ's newest database. Jen?
Thanks, Herb. So in order to create the 3PRD, we came up with a 6-phase development plan where we planned what we were going to do and the data that we were going to acquire. We went through the acquisition process. Then in order to be able to pull everything together, we processed the data to bring disparate data sources into the same kind of format, standardized and harmonized variables so that everything would be aligned with one another. We then took those data, disparate data sets that were standardized, and we built the 3PRD. We then went into a testing phase to make sure it met certain quality standards. And we are now in the sharing stage where we're sharing this information, and Herb will actually go through sharing when the files will be available for use by external researchers in the future. Next slide, please. So during that initial stage of planning, what we did is we did an environmental scan to determine what kind of data sources are out there for us to use that contained information on physicians and physician practices. We identified kind of 3 groups of data sources. The first are data sources that are common to states, meaning that the information these data sources contain information that are common to all states. This includes data sources such as the National Provider Identification Database, NPAS, that produces the NPI, the Federal State Medical Board database, and the AMA master file that has information pertaining to individual physicians. Information pertaining to practices is the CMS's MD PAS, PACOS, HCRS, and IQVIA's OneKey data. Then there were data sources that were unique to states. This means that the information contained within the data source is unique to the population within that state. So the APCD, such as Arkansas's APCD, falls within this data group. The information contained in the Arkansas APCD, it reflects the population of Arkansas or reflects the population that are treated by physicians within Arkansas. The other data source within this group is the individual state medical board data. Then we looked at 9 other data sources, such as data coming from the Association of American Medical Colleges and AHRQ's Compendium of U.S. Health Systems. Next slide, please. So when we entered into the data acquisition stage, we decided to go with state medical board data. We wanted data to actually be specific to the state rather and harmonize it as the project would dictate, rather than pulling from the federal or Federation of State Medical Board data, which was standardized data across all states. So we obtained state medical board data from 21 different states. We then conducted outreach to 7 states with currently with an APCD database, and that included Arkansas. We actually were able to obtain APCD data from 4 states, those 4 states being Washington, Colorado, Maryland, and Arkansas. We also obtained as much publicly available data as we could, such as the MPAS, PACOS, and the compendium data. Next slide, please. We then took all of these data and we started with data cleaning and validation. The data contained information that was stored in different ways. For instance, some databases stored a physician name within one field, whereas others broke up the name between first, middle, and last name. We cleaned up address files. We also did an assessment and harmonized variables across the disparate data sets. We found physician specialty or provider specialty information to be captured in different ways across different data files. So we harmonized that to align with CMS's provider specialty codes that they have used in their Medicare data. We also did provider adjudication. We found that in some data files, provider was listed as a physician, while in other data files, they were not. So what we did there is we took the information across various data sources and we identified what we could find as a consistent information across various data sources, and that's how we adjudicated the provider to the physician level. We then linked several data sets to create what we call the core physician file. This is a file of harmonized data variables along with identification of identified adjudicated physicians. Next slide, please. So this gives a visual representation of the data linkage in order to produce that core physician file. We took the NPES, which contains provider information, along with the National Provider Identification Number, the NPI. We linked that to the State Medical Board data, which contains a license number. The NPES file also contains license number, but not in a clean way. If you've ever worked with the NPES file, you'll note that they have multiple license numbers and state IDs, and we went through a process in order to link those two files together. This allowed us to put the NPI on the state medical board data. We then linked that data with PACOS information. The PACOS file contains providers that have registered with Medicare for payment, and that allowed us to get the widest breadth of identified providers within a state. This created the unadjudicated core physician file. We then looked at information across all three of those files. We also pulled in information from claims files to identify which of the providers were, as best as we could understand, truly a MD or a DO or a physician, and those which had maybe other types of credentials, such as a nurse practitioner or a physician's assistant. The 3PRD only contains MDs and DOs, so it is restricted right now to being a physician. Next slide, please. We then went through each state file and identified, through processing the data, we identified certain key variables that we wanted to have across all states. Not all states contain this information at this point in time, so we wanted to grab as much information as possible, realizing that some states will not have the information. So for the core physician file, we have produced a global 3PRD provider ID, which could be used later on if the MPI, for whatever reason, would be dropped. We have a license status. Arkansas and Minnesota were the only ones that contained information on physicians for an active license. And again, this is actually coming from the state medical board data. It's not even coming from the APCD yet. So they have an active license. We have licensed states. We have physicians' names and their sex. For certain states, they indicated whether or not there was a military affiliation for the physician. Certain states also provided information on board certifications and medical school locations. And then we also included in that core physician file the harmonized specialty information. Next slide, please. Once we harmonized that information across those 21 states where we collected state medical board information, we finalized and narrowed it down to 13 states, which comprise the 3PRD. Those 13 states included all 4 states that provided APCD information. Those are Arkansas, Colorado, Maryland, and Washington. We included states that have APCD programs or are developing programs, such as California, Florida, Massachusetts, Minnesota, New York, and Texas. Some of these states, the reason why they weren't included as APCD states was because in order to access their data would take too long and extend beyond the duration of the current project. But they did have data that would be available and could be incorporated at a later point in time. Finally, we incorporated states for geographical representativeness. Arizona is included for representing the Southwest region. Missouri was included as it borders Arkansas, and Montana was identified as a frontier state and included to represent that region. Next slide, please. Once we identified the 13 states and had all variables standardized across these states, we started to incorporate information we gathered from the claims data. All 13 states include CMS Medicare fee-for-service data, and all states include Medicaid data, although the data for Medicaid comes from various sources. For Arkansas, it is derived from the APCD. For non-APCD states or states where the APCD did not provide Medicaid information, we took the information for Medicaid from TMSIS. Only states with an APCD data include Medicare Advantage information and data from commercial populations. Next slide, please. So the physician database within the 3PRD includes the NPI. It includes a variable that flags those physicians that actively practice. By actively practicing, that was identified if they submitted a claim during the study year or calendar year. It indicates the types of insurance that were billed, whether it's Medicare, Medicaid, or if a commercial payer was billed. It gives different patient demographics, such as age variables, patient sex, population sex, and race. We have the number of claims per month, total and by payer, the number of patients per month a physician sees, total and by payer, the claims per patient per month, again, broken out by payer, and percentage of claims by payer. This was to identify the number of, the volume of claims that a physician might see if they see like a largely Medicare population or commercial population, Medicaid population. Hopefully this variable would help provide that type of information. We also included the type of procedures performed and the diagnoses observed. Next slide, please. For the practice variables, what we did is we took the physician file and the claims file, and we identified from the claims information the TIN, the organizational NPI, and the servicing zip code. And we tried to triangulate where the service was actually provided. This is not foolproof, but it is, we did find that we were able to triangulate to some degree of certainty for a lot of the claims where a service was provided. So we used that concatenation and we produced a physician practice ID. We also included the organizational NPI. We identified the number of 3PRD physicians associated with that practice, the number of other providers, such as a nurse practitioner that was associated with the practice, the total number of providers associated with the practice, demographics of the patient panel, claims and patients per month the practice sees, the most common specialty. We have flags for whether the practice is primary care focused, it's a medical practice or a surgical practice, whether they have hospitalists or if the practice is hospital based, and the zip code of the practice. Next slide, please. We then did some benchmarking. For the 3PRD physicians, we identified a little over 25,000 3PRD physicians. We looked at the Association of American Medical Colleges workforce survey, and the workforce survey identified a little over 18,000 physicians, which is a difference of about 7,000 physicians. We do expect this within the 3PRD, as if you remember, we had that flag indicating actively practicing physicians. So we may have someone with an active license, but they don't actively practice. So they may be researchers, they may be administrators, so they may not be actually showing up in the workforce survey for some reason or another. We also did an assessment of the impact of self-suppression. Given the fact that this is using claims data, which is sensitive data, we did use self-suppression for providers which might be serving a population that would contain very sensitive information. So sometimes information has been suppressed within the 3 PRD. Next slide, please. We also did analysis of outlier data. Since it comes from claims, the claims data not only represents what's billed, but it might also represent policies that underlie how billing occurs. So we did a visual inspection and looked for outlier information and compared those outliers to the total 3 PRD and other physicians within the 3 PRD. Next slide, please. So in the case of Arkansas, the physician that was associated with the most claims per month had a maximum of 14,000 claims per month, which obviously seems a bit excessive given one physician. The next closest 3 physicians had 3,200, 2,800, and 2,200 claims per month, respectively. The physician with the most claims in Arkansas is based in Little Rock, Arkansas, specializes in infectious disease, and was the medical director for immunization for the Arkansas Department of Health. We found this to be consistent with what we were seeing in other states, where you can have claims being billed under one physician or one NPI, but they may be other providers that are falling under that NPI. So although initially this may look to be an outlier, there is a reasonable explanation for why this might occur within the claims and therefore within the 3 PRD. Next slide, please. So this is the finding. We found that this pattern was seen among physicians in certain specialties such as radiology, pathology, immunology. This is a common pattern that we did see not only within Arkansas and within specialties, but across the 13 states. Next slide, please. The physician and the physician practice files are linkable. There is the global provider ID, which will allow for the identification of providers across the state lines. And then we have identified through our testing that this database can be used to identify the number of physicians with a license in the state, the number of physicians with an active license that actively provide care, and the number of physicians with licenses that recently expired that during something like a health emergency may be able to be called upon if necessary to provide additional care. So the question is, how long did it take to execute this project? This project was, I believe, 18 months long in total. From the time that we started data acquisition to the time that we completed it was about 18 months. We did evaluate the data sources independently and sequentially first. We did evaluate each data source independent of one another. We also then did we looked at the patterns across each of these state data files, if that helps clarify that question. Next slide, please. We then created 3 different types of files. We created a public use file, or PUF, which is a directory of physicians and practices. This does not contain any variables that were derived from the APCD. We created a restricted use file, or RUF, which has limited variables from the APCD. And then we created a geographic puff, which aggregated information up to a zip code level. Next slide, please. And we are available for questions now, or you can forward them to us later if we are short on time, Kinley.
Thank you so much, Dr. Smith and Dr. Wong. I knew we were at the end. That's why I submitted that question. Kathy, did we have any other questions in the chat? No.
No, there don't appear to be any other questions in the chat yet.
Well, that was incredible. A provider file is like a unicorn, right? Something you really want and hard to find. That is incredible work. And I remember working with you and Josiane during this process to get data and get everything reviewed, et cetera. And it was very exciting. I'm glad to see the results. So, and you will be getting more questions from me offline. So, all right, thank you. Let us move to our next topic. Mike Motley and Sarah Crawford from ACHI. They are going to talk about Arkansas breast cancer screening analysis. And Mike, Jennifer Medley will run the slides for you.
Wonderful. Thank you so much, Kinley. And it's a pleasure to be presenting to you all this afternoon. Just want to make sure everybody can hear me before I dive in. I'm seeing some heads nodding, so that's great. Yeah, so we just wanted to touch on a quality metric that we have recently looked at in the Arkansas All-Payer Claims Database data, which is breast cancer screening or evidence of mammographies. On the first slide in the presentation, just the question is, what percentage of women aged 50 to 74 had evidence of a breast cancer screening in our available data in the APCD? I'm sure you all are very familiar with the background and the importance of this screening. Breast cancer is the #1 cancer type among women in Arkansas and in the country, and the second leading cause of death. And obviously, early screening and prevention can help avoid adverse outcomes and unnecessary treatments and things like that down the road. So our design overview for this, we looked at 2019 as the last pre-pandemic or kind of normal year in terms of utilization, and the last year of, at the time, available Medicare fee-for-service data, which represents a large chunk of this eligible population. The denominator population is women that were aged 52 to 74 as of December 31st, 2019, who were continuously enrolled in a single coverage type from October 1st, 2017, all the way through the end of 2019. And if any of you are familiar with the HEDIS Health Effectiveness Data Information System, the HEDIS metrics, this is built along those guidelines in large part. So we're going to talk about continuous enrollment and continuous coverage today, but this is a project that used that continuous enrollment criteria to ensure that you have line of sight, as we say, on any numerator events or relevant experiences that happened in that study period. On the next slide, we calculated rates statewide and by county. This information is not exactly readily available. There are other survey-based indicators, but they're subject to self-reporting bias and some of these things. So we wanted to go from a claims perspective. The populations include an overall state population of the eligible women, and then by coverage type. So Medicare, Arkansas Medicaid, the AR Home program, which is Arkansas's version of Medicaid expansion. It has had a few different names, and that is the current name. And then commercial coverage, which includes some state-based self-insured groups, our state and public school employees plans, and our university system as well. Some limitations were we had a lack of data from non-claims-based screening events, so things such as pop-up screenings or public health services. Arkansas's Department of Health for a couple of decades has been running a breast care program where they provide screening services for women that are eligible that meet certain criteria around income and insurance coverage status. So we did reach out to the administrators of that program, and they confirmed that when a claim would still be billed for someone in that program, and that most that had coverage would not be eligible for that program. So we know that's a limitation, maybe talking in the hundreds of numerator events over tens of thousands of overall numerator events in the state for screenings. On the next slide, this is the statewide results. I'm not going to go too deep dive into the results because this is a pretty common metric, but we had 51% of eligible women had a mammogram in the previous just over 2 years as of the end of 2019. You see some county level variation there, particularly in the western part of the state. Those darker red counties range anywhere from 38% to 55%. And this is lower than national benchmarks. National commercial and Medicare benchmarks would be closer to around 70%, while a national Medicaid benchmark would be around 54%, 52%, somewhere in there. So we don't have the payer split, coverage type split out in this presentation, but we did see some variation across coverage types. We released this as part of a infographic to coincide with Breast Cancer Awareness Month. On the next slide, the methodology that we want to highlight today is what we call continuous enrollment versus continuous coverage. Some of you may be familiar with this, but many studies require that you limit your study population to those individuals that had continuous insurance coverage over a designated period in order to be able to observe their entire experience across that period. So studies that seek to compare experience across coverage types may require continuous enrollment. So if you want to compare one plan experience to another, you'd want to have individuals that were just in one plan or one plan type for the designated study period. So things like quality measurement, the breast cancer screening and other screenings, other studies that seek to assess any evidence of outcomes of interest may only require continuous coverage, which I'll get to that in a moment more on that. But if you're looking for disease incidence, and you're not as interested in where the coverage type where that was documented in a claim, you could just require continuous coverage across different types of coverage. And then I'm going to turn to Sarah Crawford, who was our lead analyst on the breast cancer screening piece, to talk more about continuous enrollment versus continuous coverage.
Okay, so hi guys, I'm Sarah. So our working definitions of continuous enrollment and continuous coverage. Continuous enrollment is counting of individuals who had evidence of continuous enrollment in only one coverage type within the time period. And for this one, it was with no more than a 45-day gap in coverage. Continuous coverage is counting of individuals who had evidence of continuous enrollment in one or more of the coverage types within the time period. So it's a little bit different, just in that with continuous coverage, it doesn't matter what the coverage type is. You can be jumping around as long as you are covered by some kind of insurance plan. You can still end up in that count of individuals with continuous coverage. With enrollment, that's not the case. You have to have the same coverage type throughout the time period. You can go to the next one. So for continuous enrollment, what you want to do is identify each member's plans by coverage type. So it's the first thing you're going to do is figure out what your groups are and group or label each of your plans with that group type. So for this particular one, we used Medicare, Medicare Advantage, Medicaid, QHP, and commercial. And then you want to create a new field that compresses that new type of coverage that you just identified with their study ID. And study ID again was their hash, gender, and date of birth. So you'll compress those two fields together so that each study ID for each line of coverage has a field that has their study ID and coverage type. So if they have multiple commercial plans over the time period, they have that field is going to match on all those plans. Next slide, Jennifer. Individuals may have multiple coverage type study IDs during the time period in question. And an individual may also have multiple plans under coverage type study ID. So an individual may have multiple commercial coverages that span the time, but be considered continuously enrolled in a commercial plan during the time if they meet the rest of the criteria. So even though they have multiple commercial plans, if they all roll up to meet the criteria, they can be continuously enrolled in the commercial category. Next slide. So you'll perform your continuous determination based on that new coverage type study ID that was created to find if a person qualifies as continuously enrolled. If you're doing it just continuous coverage, you can perform the same code on just the study ID rather than the compressed study ID and coverage type. So your results for a continuously enrolled population denominator are going to end up being less than what your results would be for a continuously covered population denominator. And as Mike said before, it's helpful to do it this way when you're trying to determine if there are differences in utilization between people that have different coverage types. And I think that might be the last one of ours. Maybe.
I think so.
It is. Kenley?
Thank you so much, Mike and Sarah. It wouldn't think it would make that much difference, and there are a lot of assumptions out there about claims data. I've talked to many a data user who thinks that if you have health insurance, it's just one carrier, and it's problematic, obviously, when you have to look at the bigger picture. So this is really good information. All right, in the interest of time.
We do have one question, Kenley.
Oh, yes, go ahead.
Mario asked if this included screening and diagnostic mammograms, and were women previously diagnosed with breast cancer, or were double mastectomies excluded?
Yes, so those, all the exclusions that are in the HEDIS guidelines were excluded from our denominator population. So that is people that had double mastectomies, there's some other small things in the guidelines that are, it takes a long time to run those exclusions actually, because there's quite a few of them, at least for breast cancer. Some cancers, there aren't that many, but for breast cancer, there's a lot. So we did do those guidelines as closely as we could based on the information that we have. So I think there's like one thing in the exclusions that we don't really have access to, but it's really close. And then what was the second part of the question?
Did you include screening and diagnostic mammograms?
Yes. Any
Okay.
mammogram is included. Yep.
All right, and we have one other question. Will you do similar analysis of screening rates post-COVID? Mike?
Yeah, I think we certainly will. We now have Medicare data through 2020. We have commercial Medicaid data. It's Medicare fee-for-service. We have Medicare Advantage through parts of 22 and commercial and Medicaid as well. So we certainly plan to update this and look at if any impacts of COVID impacted utilization in terms of primary screening for breast cancer.
Okay, thank you. That's all we have, Kenley.
Thank you, Kathy. I'm sorry, I jumped ahead. So Jennifer, if you wouldn't mind going back to the deck, and in the interest of time, I promised an hour. Geez, it's slow. The electrons are slow. Jennifer, are you there, Jennifer?
I'm here. Just sorry, I closed it. Give me just a moment.
Oh.
I apologize. I thought we were finished with it.
No. So in the interest of time, I'll give everyone a teaser of the next couple of slides. I have some slides. I have an example of some data use from Colorado having to do with determining cost of care at private ambulatory hospitals versus other hospitals, and their analytics showed that for this particular time period, it was average savings was about 44%. When you get the deck after this meeting, do look at that slide because it's very interesting. They have it published on their website, and the link to the findings is there. And the second example I have included is from the state of Virginia, where they utilize their all-payer claims database and their state's medical board to build a provider file. The project was published in the Annals of Family Medicine. The link to the article, is in the deck. So let's go to the next slide real fast, Jennifer, so everyone can have a visual. You can see, if you go out to the Colorado APCD site, the link is on this slide, but you can see this study and the findings and get more information. Okay, let's go to the next one, because there's something I want to get to after this. Here's the Virginia work, and there's several slides here that outline the methodology they use, but ultimately what they were trying to do is identify primary care physicians in Virginia. And they felt that based on their work, they got very close and felt pretty good about the results. Now, it was just those two data sources, the MPI file and the APCD. I said board file before, I was wrong. Anyway, you can see this in relationship to the AHRQ project we just looked at. Yeah, so next slide. But for all of you, and let's go to the next one more. All right, one more. Yay. All right, because we just have a few minutes left. For all of you data users or potential data users out here, I like to always show this slide because this is an inventory of really good data user resources. Each one of these is a link to a document on our website that helps you understand the data that's available and can help you use it. Again, always reach out to us if you have questions. The deck that is in the helpful hint, the data attributes deck, will help you, is very useful in helping you identify not identify individuals, but find representations of individuals and using our hash ID. But you see the blue arrow in the middle there, it's pointed to a bullet that's called DSG 8.0 changes. And it's important to talk about that briefly with this group of people. So let's go to the next slide. Okay, so DSG stands for Data Submission Guide, and the Data Submission Guide is the document of requirements we give to carriers to submit data. All the carriers submit data in the same layout and are supposed to populate all the fields the same way. And periodically, not very often, but periodically, we have to change the DSG. We're on version 8.0 now, and those change requirements were published in December of 2021, and the carriers were required to provide the data, the new data and data changes by June of 2022. Well, there were many issues, and many carriers didn't get it done in time, and they're still working on it. And we hadn't published a database really with these changes until the last one, and the one that is available now is through June of 2022. Mike alluded to how we had some 2022 data. So I wanted to tell you about these and show you what they might mean. And please ask questions either here or after if you need to. All of the changes are in the release notes that you see linked here, all of them. Next slide. Quick summary. We have new fields and we have changed fields. The new fields we've tacked on where possible, well, almost exclusively to the end of the record. So you don't have, if you're already using these data and you get a fresh set of data, you don't have to move around your data layouts. We have added on, and you might recall that the two letters in the front of the data element number represent the file type. DC is dental claim, MC is medical claim, PC is pharmacy claim, ME is member enrollment. And so we've added the Medicaid aid category to each of these. It used to be just on the member file in a different field, but now it's expanded, and where possible, it's 4 digits instead of 2. For those of you who are familiar with Medicaid data, you'll know what I mean. We might include Medicaid state aid category as a topic in our next data user group. Let me make a note of that. That would be a really good thing. And then we have added some additional indicators for Hispanic indicator and then payment arrangement type. Let's go to the next slide. I think I have some more new fields. Point of origin code, you can see this here, what they are and their definitions. Data types, etc., are in the data dictionary, which is linked. You can get to it through our website or through the release notes. Next slide, please. The next slide or two is about changes to existing fields, and largely the changes are, we had several fields focused on race and ethnicity that were optional, which meant that the carrier didn't have to populate them. Now, admittedly, and we all know that commercial insurance doesn't typically have race and ethnicity information. If they did have it, thank you, Kathy, for that link. If they did have it, they didn't have to populate it because these fields were optional. But going forward, these fields are required, so they have to populate it if they have it. I can tell you that almost no commercial carrier has these data, and so they have had to ask for an exception not to provide it. But it's a placeholder and it's there where the data is available. The next one on this is ME040, and that is where the Medicaid state aid category used to be. And it is holding data at the federal aid category now. But as you look at these changes, please look at this field in relation to those 9-10 fields that we saw on the previous slide and ask questions, because it's similar data just in a different place. Next slide, please. More changes, again, some optional fields that were now that are now required. Grandfather status has some new data elements, and the 5 fields at the bottom that have to do with discharge, admitting, et cetera, et cetera. Those fields used to just be inpatient, but now they include all institutional claims, not just inpatient. All right, next slide, please. I think that, don't forget to look at your data tips. The data tips link is on our website. It's live in this deck. If you are not on our email list to get our data tips email, we send it monthly. Please let us know, we'll add it to it. And we have several, it's important. Many of the carriers have nuances in their data that require a little extra attention for you to be able to have truly usable normalized data. So next slide, and I believe that's it. Don't forget your data tips. Next slide. And if ask questions, send questions to this email address. Next, one more slide, and that's it. Our next data users group is October 26th, and let's talk about Medicaid state aid categories. That's 1 hour, everybody. Thank you for coming and attending. It was a great session. Reach out to us. Talk to you later.